Hey everyone, thanks for tuning in. Steven here with Team Euphoric, and this is day 8 of the 80 Days to Your Dream Body course. Today's protein source is going to be beef short ribs, and it is going to be a legs and abs training routine. And the theme for today's video is going to be structural balance for improved athletic performance. So right now, I'm going to be teaching you how to assess an athlete's mobility. Let's get started. And while we are resting, let's move on to the theme of today's video, which is going to be structural balance for enhanced athletic performance. Structural balance is going to be very important. The first thing that we're going to do in the structural balance assessment is going to be a mobility assessment. With regard to mobility, if you have any athletes that are involved in speed, strength, or power sports, mobility is going to be very, very important because it's going to allow them to generate the most maximum amount of force possible. In physical therapy, there is this concept known as active insufficiency and passive insufficiency. With regard to passive insufficiency, that is when a muscle that crosses multiple joints cannot maximally stretch at both joints that it crosses. So an example would be the rectus femoris. The rectus femoris crosses the hip and knee joint. So if you were to maximally extend the hip, you're not going to be able to maximally flex the knee or stretch the knee joint because it's being stretched from both ends. And same thing with active insufficiency. With active insufficiency, let's say the semitendinosus, if you are going to try to maximally contract it, you're only going to be allowed to contract it maximally at one joint that it crosses. So if you fully extend the hip, then you're not going to be able to flex the knee maximally because it's already being maximally contracted at the hip. This is very important for physiotherapy and also in with regard to performance. Because let's say you have a sport where the athlete does a lot of running. If they have very, very tight rectus femoris, what's going to happen is when you are running, you need hip extension to propel yourself forward, and then you also need knee flexion to get the leg up. So if you have a really, really tight rectus femoris, what's going to happen is you're not going to be able to get full extension of the hip and full flexion of the knee, which is going to minimize the amount of power that you can generate when you are running. And then with regard to the actual athlete itself, you would want to perform some type of either myofascial release or some type of manual therapy to be able to get greater range of motion in the actual hip and knee. But with regard to today, we're going to be going through the lower body for the most part. We're going to do one upper body assessment to test mobility, and that is going to be the Apley scratch test. With regard to the Apley scratch test, it is 3 parts. The first is horizontal adduction. So you're just going to reach across and have them touch their shoulder. And if they can do that, pretty much any type of horizontal pressing is going to be fine. You could also do an impingement test by having them lift their elbow up to the sky to see if there's any restrictions. From there, you would then do you would go overhead. So you would do maximal flexion, external rotation, and abduction, abduction by having them try and touch the opposite shoulder blade. If they can do that, then any overhead pressing, they have good mobility for that. And then the last one is going to be extension, medial rotation, and adduction. You're going to have them go ahead and try and touch the opposite inferior angle of the scapula. If they can do that, then they're going to be good for pulling and things like dips. But right now, rest is up. Time for set number 2. And while we were resting, let's move on to the lower limb assessment. And for the lower limb assessment, I got my good buddy, Johnny Bones, helping me out right over here. And we're going to need a couple pieces of equipment. Ideally, you would want a goniometer, and this is optional, but I love having a bubble level attachment to the goniometer. And we're also going to need an inclinometer. If you don't have these, you can eyeball it, but ideally, it would be great to own those 2 pieces of equipment. The first part of the assessment, we're going to start at the hip, and we're going to start by checking out the range of motion in the gluteus maximus muscle. For the gluteus maximus muscle, by the way, all of these you want to be on the side that you are assessing. But for the gluteus maximus, you would want to go ahead and you would want to flex the knee to 90 degrees, plant the foot on the floor, and then you would want to push their thigh across the midline so you could get your hand underneath their lumbar spine. From this position right over here, what you would do is at the proximal tibia, you are going to bring them into hip flexion until you feel the spine move down into your hand. As soon as the spine moves into your hand, then all of a sudden, it is no longer the glute max because now the erector spinae group is going to be getting involved. So you would stop it as soon as you feel a little bit of the pressure in your hand. And ideally, what you would want to see is 125 degrees range of motion in the glute max. The way that you would assess that is you would take your goniometer and you would want to palpate the greater trochanter of the femur, and whatever angle the foot was at when you ended up feeling that little give, that's where you would keep it. So you would just hold the position. This is where the bubble level attachment comes in handy, because with the bubble level attachment, you don't need to place the pivot point at the actual greater trochanter of the femur. You could just place it anywhere you want and make sure that the bubble is level. But if you don't have a bubble level attachment, you would place the pivot point right at the greater trochanter of the femur. You would want to make sure that it is nice and leveled, and then you would just go ahead and check your angle. And again, 125 degrees is what you would want to see. The second assessment, we are going to do the semitendinosus. For the semitendinosus, you are going to flex the hip to 90 degrees. And then once the hip is flexed to 90 degrees, you're going to do the same thing. You're going to push them over, put the hand under the lumbar spine. And then for this one, you're going to grab a hold of the calcaneus and bring them into knee extension. Same thing, as soon as you feel that the lumbar spine pushes down into your hand, you're going to stop. Once you stop, you are going to take your goniometer. You're going to place the pivot point at the lateral condyle of the femur. And then you just want to measure what exactly the angle is at the tibia. And for this one, ideally, you would want to see between 160 and 180 degrees. The rest is up. Time for set number 3. And while we were resting, it is time to move on to the hip abductors and adductors. With regard to the hip abductors, when we are testing the abductors, we are taking them into a deduction, so across the midline. And for this one, so the opposite limb does not get in the way, you would instruct the patient to hold their knee or their shin toward their chest. And Johnny's a great patient right now because he's doing everything that I need. For this one, ideally, I like to use the inclinometer, but you can use the goniometer. If you're using the inclinometer, you would take the north arrow, you would place it at 0, and then you would have it resting on their thigh. And then for this one, what you would do is you would place the moving hand underneath the distal tibia and fibula. And then with the stabilizing hand, you would place it at the greater trochanter of the femur, and you would take them into a deduction until you find that the greater trochanter of the femur protrudes into your hand. Once it protrudes, you would stop right there and you would go ahead and take your reading. The great thing about the inclinometer is you don't need to play with anything at all. You could just set it on the thigh. As long as you zeroed it out properly, you're going to get your reading. However, if you don't have an inclinometer, you would go ahead and take your goniometer. You would palpate the greater trochanter of the femur, and then right in the center of the femur at the greater trochanter, you would place the pivot point. So one would be completely vertical, and then the other one would be directly over the center of the femur. And with regard to the hip abductors, they should be able to get at least 30 degrees of a deduction. And Johnny right here, he is at 14 degrees, so he's very, very restricted. Next, we are going to measure the adductors. When we are doing the adductors, we are taking them into a abduction. So for this one, we can just have them relax. We don't need them doing anything with the opposite limb. And when we are doing the abductors, we are going to go onto the opposite ilium. So what we would want to do for this one, because the adductors all attach somewhere around the pubic bone, as soon as we find that there's a little bit of movement in the ilium, we would stop. But we would go ahead, take the moving hand, and we would place it same spot at the distal tibia and fibula. With the stabilizing hand, we're going to press down at the ilium, and then we're going to take them into a abduction to test the adductors. As soon as you find that this hand starts to kind of move a little bit, you would stop immediately. And same thing, if you were using the inclinometer, you would just zero it out in that neutral position, and then as it moves, you would see exactly where it is. If you are using the goniometer, you would palpate at the greater trochanter of the femur, and then estimate where the center of the femur is. And then having it vertical, you would take the stationary arm, place it vertical, and with the moving arm, you would go ahead and see what the actual range of motion is. And ideally for the hip abductors, you should see for the hip adductors, you should see anywhere from 30 to 50 degrees of range of motion. But rest is up. Time for set number 4. And while we are resting, we have 2 assessments left in supine position. The first is going to be for the gastrocnemius. For the gastrocnemius, we are going to be using the goniometer, and we want to take the pivot point of the goniometer, and just inferior to the lateral malleolus of the ankle is where we are going to place it. You're going to start with the goniometer at 90 degrees. And what you would do is when you place the pivot point at the ankle, the stationary arm, you would want it in line with the fibula. And then you would instruct the patient to dorsiflex or bring their toes toward their head as much as they can. Once they bring their toes as close to their head, the moving arm, you would want it placed right on top of their pinky toe. So once they move, wherever their pinky toe ends up pushing it to, that is going to be the angle that they're at. And ideally, they should have anywhere between 10 to 20 degrees range of motion of dorsiflexion in the ankle. Next, we are going to move on to the Faber test. For the Faber test, this one right over here is a special orthopedic test. We don't need any equipment. And all we are going to do for this one right over here is go into flexion, abduction, external rotation. The Faber test, it has 3 different names. It's the Faber test, the Patrick's test, or the figure 4 test. The figure 4 test is an easy way to remember it because it looks like a figure 4. Faber is also great because F, flexion, AB, abduction, ER, external rotation. What you're doing for this one right over here is you are going to flex the hip and knee, place the ankle over the top of the patella, so superior to the patella, and then you would bring the hip down toward the floor. For this one right over here, this is just going to indicate general pathology in the hip. If they are very, very restricted or if they have any type of sensation of pain, it's not going to be very useful in determining what specific condition they have. But again, for just a general recommendation and just general hip pathology, it is a great assessment to perform. That concludes the portion for the supine position. Now we are going to move into sideline position. So for the sideline position, what you would want to do is have the patient flex the hip and knee. That way they can be nice and stable on the table. Otherwise, they're going to be flopping all over the place. And what you would do for this one is there are a few assessments, but do we have enough time? Yeah, we got about 30 seconds. So the first one that we would want to do is we are going to do the Ober's test. For Ober's test, you're going to stabilize at the ilium. And then with the leg, you're going to flex the knee to 90 degrees. You're going to bring them into slight extension. You're going to bring them into abduction. And then what you would want to do is see if you can bring their knee down toward the floor. If their knee can go down toward the table, then that indicates that they have good length tension in the tensor fasciae lati muscle. But rest is up. Time for set number 5. And while we're resting, we're going to start performing the assessments in prone position. The first is going to be for the lateral rotators of the hip. And for the lateral and medial rotators, I love using the inclinometer because there's this little groove that fits perfectly into the Achilles tendon. So what you would do is you would zero it out against the 90-degree surface. And we're going to be using the blue gravity line when we are doing this one. But what we would do is with a supinated grip, we're going to go under the distal tibia. We are going to place that groove right into the Achilles tendon. We're going to hold it with our thumb, flex the knee to 90 degrees, and we want to make sure that the tibia is completely vertical. Then, with the stabilizing arm, we are going to apply a downward pressure at the sacrum. And when we are assessing the lateral hip rotators, we're going to take the patient into medial rotation. So we're going to bring the leg toward us. As soon as you notice a little bit of tightness, you would automatically stop. You're not going to let it go even further because then we're going to get other muscles involved. And then once they stop, you would just move your hand out of the way, take a look at your reading. And for the lateral hip rotators, ideally there should be between 30 to 40 degrees of medial rotation. Then when we are assessing the medial hip rotators, we're going to take the patient into lateral rotation. But same thing, we're going to take the inclinometer. We're going to place it at the Achilles tendon. We're going to cup the distal tibia and fibula. We're going to stabilize it with our thumb, take them over here. The only difference is the stabilizing arm, we're going to place it at the greater trochanter of the femur. Then, when we are assessing the medial hip rotators, we're going to be taking them into lateral hip rotation by moving the ankle away from our body. For this one, once we move away, we want to take a look at what the greater trochanter of the femur is doing. As soon as it protrudes into your hand, you would automatically stop. Remove your thumb, take a look at the reading, and ideally, they should have between 40 to 60 degrees range of motion. With regard to these two assessments, we could also use a goniometer if you don't want to use an inclinometer. If you're going to be using the goniometer, you would take the pivot point and you would want to place it at the center of the femur. And then with the stationary arm, you want it to be completely vertical. And then with the moving arm, you would want to just trace it over the tibia. So however far they were able to get, you would just go ahead, move the moving arm over, and then get your reading. But that is how you would perform it with the goniometer. Next, we are going to be performing the assessment for the quadriceps. For the quadriceps, what we would want to do is, I'll tell you in about 10 seconds, because right now our rest period is up. So time for the 6th and final set. And while we are resting, let's assess the quadriceps. For the quadriceps, there are a couple different ways we could do it. We could either do it on the side of the patient, or we could do it from the bottom. If we're going to be doing it from the side, the way that we would do this is we would take our palm, we are going to place it in supination, we are going to go with the distal tibia and fibula, and then with the stationary or with the stabilizing arm, we are going to apply a downward pressure at the sacrum, and we would want to go ahead and we are going to flex the knee until we notice a little bit of movement at the pelvis. As soon as we notice a little bit of movement, we would stop because that means that the rectus femoris is starting to get involved and it's starting to pull the pelvis out of position. So we're going to get other muscles involved if we go beyond that point. Let's say they stop right over here. We would want to go ahead and take our goniometer. With the stationary arm, we would want to position it horizontally. And then with the moving arm, what we would do is we would go to the lateral condyle of the femur, and then we would want to go ahead and trace the fibula. From there, we would take our reading, and we would want to see 135 degrees. The other way that we could do this, we would not use a stabilizing arm. We would just use a moving arm. So if we're doing that, we would come to this position right over here, and we would want to observe what the pelvis is doing. So as soon as we see the pelvis move, we would stop immediately and then do the same thing. We would take our measurement by taking the pivot point, placing it right at the lateral condyle of the femur. The stationary arm is going to be horizontal, and then wherever they stopped, let's say they stopped right over here, you would just trace the tibia with the moving arm. And I'm just doing this so you can see exactly what would be going on the opposite side. But obviously, when you are performing it on a patient, you would actually measure on the side that you were on. The last one in prone position is going to be for the soleus. The soleus is a plantar flexor, so we're going to do the exact same thing as the gastrocnemius, only we are going to flex the knee to 90 degrees. But for this one, same thing. We're going to start with the goniometer in a 90-degree position. So what we want is the stationary arm completely vertical. Once the knee is flexed, just distal to the lateral malleolus of the ankle, we would pin it in place. And then what we would want to do is make sure that the tibia is completely vertical. We would want to place the moving hand right over top of the dorsal surface of the pinky toe, the fifth metatarsal. And then what we would do is ask the patient, I want you to point your toes down to the floor as much as you can. They would actively go into dorsiflexion for this one. So this one, it is not a passive assessment. And then once they go into maximum dorsiflexion, you would stop, you would see where exactly the reading is. And ideally, just with the gastrocnemius, the soleus should also be between 10 to 20 degrees. But rest is up, time for set number 2. And the last 2 assessments are going to be performed in a seated position. And I don't trust Johnny to sit up by himself, so I'm just going to let him lay down. But first test is going to be for tibial torsion, and we are going to need the goniometer. With the goniometer, we want to take the pivot point and the 90-90 on here, and we want to place it directly in between the lateral and medial calcaneus of the ankle. Then, what we want to do from here is with the stationary arm, we want it in line with the femur, and the moving arm, we are going to rotate it outward, and we want it to trace the center of the second toe. We would then go ahead and take a look at our reading, and ideally, you should have less than 20 degrees of lateral rotation. If it is greater than 20 degrees, if it is 20 degrees or greater, that would indicate tibial torsion. The next test is going to be the Thomas test, and for the Thomas test, we are going to have the patient get up off the table. They are going to do a couple of marches on each leg, and then you want them to have their gluteal fold right at the edge of the table, and you are going to instruct them to fall back and hug their knee to their chest. Johnny is higher up than I would like a patient to be, but for a real patient, gluteal fold and hinge back. And then you would place one hand in the thoracic spine and just guide them as they fall back so they don't hit too hard. But they would be in this position right over here. They would be holding on to their leg. That way you could actually get a good reading on the opposite leg. And then at the opposite leg, we want to look at a few things. First, we're looking at the greater trochanter of the femur and the lateral condyle of the femur. For women, it should be below parallel. For men, it should be parallel or lower. If the lateral condyle of the femur is parallel to the greater trochanter of the femur or higher for women, or if it's parallel or higher for men, then that could indicate tightness in either the psoas major or the rectus femoris. The way we would differentiate if they are in flexion is we would passively extend the knee. And if the leg drops down, then we know the tightness is coming from the psoas major because we just released tension in the rectus femoris. Then we would want to take a look at, is it completely straight and in line with the body? If the femur is inward, so if it is in adduction, that could indicate tightness in the adductors. And if the shin or if the femur is located outward, then that could indicate tightness in the abductors like the TFL or the gluteus medius. And then we also want to take a look at what is going on with the tibia and the ankle. Ideally, the tibia should be completely vertical. If it is extended outward, that could indicate tightness in the quadriceps, so either the vastus medialis, lateralis, intermedius, or the rectus femoris. And we want to take a look at what exactly is the ankle doing. If the ankle is inward of the knee, then that could indicate tightness of the deep lateral rotators of the hip. And if it is located outside of the knee, that could indicate tightness in the medial rotators of the hip. But that is the Thomas test. Rest is up. Time for set number 3. Thanks for sticking around until the end of the video. Be sure to like, share, and leave a comment as it'll help the algorithm. And if you enjoyed the content, show your support by subscribing to the channel by clicking on the icon in the bottom right corner. And if you really want to show your support, then consider becoming a member by clicking on the icon in the bottom left corner. These new high-quality videos aren't cheap to edit, and the $5 membership will really help with the video editing budget. You'll also get access to a ton of exclusive perks like early access to videos and this program design lecture playlist in the top right-hand corner. And if you want to learn how to do a one-armed pull-up, then check out the playlist on the top left corner.